Right, good morning. Today is December 12th, and we have the Brattleboro Retreat fiscal year 26 budget. We have a staff recommendation, and we have a potential vote noticed. That's the only substantive agenda item. So I'll turn it over to Matt Sutter, our Director of Health Systems Finances.
Thank you, Chair Foster. Let me get our slide deck. Is that visible for everyone? Great.
Yes.
So as Chair Foster said, our agenda today is going to be we're going to give a quick background on statute rule and the FY26 budget guidance, the proposed standard budget conditions, a review of the hospital budget request, and a potential vote. So beginning with some background. So the GMCB must establish a budget for each psychiatric hospital by December 15th with a written decision by the end of the calendar year. GMCB must establish budgets that are consistent with the state's healthcare goals as defined in statute. The Care Board has a process to set hospital budget benchmarks, which guide the board in its decision making. Hospitals bear the burden of persuasion in justifying their proposed budgets, and if a hospital does not meet its burden, the GMCB must adjust the budget to ensure consistency with the state's healthcare goals. We have this flow chart to kind of describe our the way staff reviews hospital budgets that we receive. The first step you can see is section 1. We review their performance against benchmarks. If they hit that, we skip section 2, which is a comparative analytics component. I will not bury the lead here. The Brattleboro Retreat did hit their benchmark. So after that, we review their budget assumptions to make sure they're reasonable and submissions are complete. And depending on that, we either recommend approval of their budget or consideration of a budget adjustment. Speaking quickly about section 1 benchmarks, just as a reminder, the board may establish a process to define on an annual basis criteria for hospitals to meet, such as utilization and inflation benchmarks. The board may waive one or more of the review processes listed in subsection B of this section. The board establishes benchmarks for hospital use in developing and preparing budgets. The GMCB meets with VAS and the HCA to obtain input, and benchmarks are provided to hospitals by the end of March. Benchmarks help the board consider whether budget adjustment is necessary, and they allow the board to exempt hospitals from hearings. Just a reminder, exempted hospitals will not have their budgets adjusted. These are the benchmarks that we established this year. NPR growth was benchmarked at not more than 3.5% above the prior year approved budgets. Commercial reimbursement rate growth is benchmarked at not more than 3% over the prior year budgets, and operating expenses at not more than 3% over the prior year budgets. I'm going to quickly go over the comparative analytics slide because it does not apply here. But this explains how GMCB staff evaluates proposed budgets that do not meet the benchmarks. Where appropriate, GMCB staff compare the hospitals to peer groups, and we review metrics such as operating efficiency, price, access, quality, and financial health in making a determination there. Staff do not set benchmarks for each of these measures. Instead, we compare these hospitals to peers to understand if the above benchmark proposal is consistent with peer experience. Both peer groups and hospital metrics inventory are included with guidance available on our website. Section 3, the budget assumptions section of guidance explains how staff evaluates proposed budgets for all hospitals, regardless of compliance with the benchmarks. So as mentioned, each hospital bears the burden in justifying its proposed budget. Staff review the budget submissions for consistency and accuracy, compare assumptions to prior year budgets and to actual hospital performance. And we may use external data sources to evaluate hospital budget assumptions as described in guidance. Taken together, sections 2 and sections 3 form the basis for the GMCB staff recommendation. And very quickly, we go to section 4, a statutory analysis. So after staff recommendations, the board does need to evaluate whether and to what extent budget adjustment is necessary for each hospital. These staff recommendations assist the board in its review, but the board must establish budgets that meet the following statutory criteria. So the General Assembly's intent in establishing the Green Mountain Care Board, principles for healthcare reform, and hospital budget criteria with citations after. Our staff attorney, Mark Henksler, is going to help walk through the standard budget conditions and for the retreat and some modifications.
Hey, good afternoon, everybody. I will be brief. You can go ahead to the next slide. So what we have here and on the next slides will be the standard budget conditions that would be incorporated into the retreat's FY26 budget order. So when we get to the end of the staff presentation, you'll see that the board's motion language includes incorporation of the standard conditions. The board considered standard conditions in the summer when reviewing the budgets of Vermont's other 14 hospitals. And what we have here is not different from those conditions already considered by the board, except for a few small items. So as a reminder, the retreat is unique in that it's the only hospital in the state that is operating on a calendar year budget instead of a budget that starts October 1st. And for that reason, throughout the standard conditions, staff just went ahead and moved up any dates 3 months to correspond to the retreat's calendar year budget. So you'll see highlighted text where the date has been adjusted up 3 months for the budget order. The other item that I just want to point to is there's one area where language that was included in FY26 conditions for the other hospitals is being proposed to be removed for the retreat. And that's at item C, which concerns a hospital's commercial reimbursement rate cap. For other hospitals, earlier this year, the board voted on language that included this provision that the commercial reimbursement rate for any payer would not be more than the amount determined over current levels. Staff are proposing that language not be included in the retreat's budget conditions. This is consistent with what the board did last year for the FY25 budget. So if you compare that with 25 budget conditions, there's no change here. And the reason for this is that the retreat has some unique commercial payer situations that the other hospitals just don't have. So that's the reason for having this. If board members have questions about removal of that section, we could certainly talk about any payer-specific commercial information, but that would need to happen in an executive session because payer-specific commercial data is being treated as exempt from the Public Records Act. So just going on to the next slides, I'm not going to read through all of these in detail at this meeting, but they're here. They're consistent with what the board has been looking at over the last, the other hospital budget conditions. But you'll just see that, again, the dates have been moved up by 3 for anything. So that the highlights are what's a difference from conditions previously considered. And then you can go to the next conditions. And then there's a final slide at the end. So for the board, I don't see a need to go through these and read them all. If the retreat is not up to date on what the standard conditions were for hospitals earlier this year, or didn't have a chance to look at these prior to today's meeting, we can certainly loop back around to this at the retreat's request and slow it down and walk through what's in here so the retreat can have any questions answered or object to anything if it has concern. But that's it for that portion.
Thanks, Mark. So I'll go through the staff recommendation. So I did want to note, so the Brattleboro retreat submission was on time and complete. The Brattleboro retreat did request an exemption from a budget hearing noting they met benchmarks established in Rule 3.202. I just wanted to just talk through this for just a second. Normally during the hospital budget process, we receive budgets on July 1. My team has a multi-week process where we review, ask questions of the hospitals, and then develop a recommendation to the board about potential exemptions. With the retreat, the timelines kind of prevented that. So we receive their budgets on December 1st. We do a review analysis. We get questions back to the retreat. They were very timely in responding. But with their hearing being on the 5th, it was logistically impossible for staff to present a recommendation for exemption. So I did want to say we did receive questions back from the hospital, responses to our questions. They were satisfactory. And hypothetically, had it been possible to receive all of those, I would have felt comfortable recommending they be exempt from a hearing. But regardless, we are here. So Brattleboro retreats, here's a slide just kind of showing their budget in the context of system-wide net patient revenue, commercial NPR, and operating expenses. You can see here that they represent about 2.6 of the total net patient revenue and 2.3% of operating expenses when you consider all the community hospitals together. You'll note here that they have a much smaller share of commercial NPR than the other hospitals in the system. This is because their payer mix is much more public payer focused than our other hospitals. Going through the Brattleboro Retreat's legislative impact slides. So impact of Act 55, Act 68, and Act 111 from 2024 for them. We first confirmed with the retreat that they do not believe they're subject to Act 55, as this is not an acute care hospital. This is consistent with our understanding as well, but they did note in their hearing that they plan to be at or below 120% ASP for their only outpatient drug, the esketamine treatment. Act 68 asks the board to consider the salaries for hospitals' executive and clinical leadership, including variable payment and incentive plans. The retreat noted in their narrative that none of the executive leaders are part of a variable comp plan, but the chief medical officer's bonus is eligible based on the terms of his contract. And then Act 111 from 2024 is an act relating to prior authorizations and step therapy requirements, health insurance claims, and provider contracts. When we asked about cost savings from this act, the retreat noted that these were not effective until January 2025. And since their new EMR went live in July of this year, they've been unable to determine whether it led to quantifiable expense reductions at this time. So these are the benchmarks they submitted. Proposed budget of NPR growth of 3.5%, which is at guidance. Overall aggregate commercial rate growth of 1.2% and operating expense growth of 2.8%. On this slide here, we can see their year-to-year budgeted NPR. So there's a few different things happening in the NPR growth. There's an adolescent intensive outpatient program anticipated to start in March. And there's been unanticipated demand for esketamine, which is an outpatient drug. The increase in Medicaid is due to the state purchasing 5 additional beds, increasing from 51 to 56 for the upcoming year. And this is offset by reductions in Medicare and commercial. The retreat's expecting a slight uptick in average daily census overall, but not enough to completely offset the additional beds designated to Medicaid. They also spoke to overall reduced demand by those payers. I want to note the adolescent residential treatment facility was baked into the FY25 budget. However, it got bumped to FY26 instead because of new EMR system replacement. And residential NPR is still anticipating growth due to increased utilization compared to the original, what was originally budgeted. Moving to commercial rate, you can see on the left a table showing the history of commercial rate requests that we've seen from the retreat here. Last year it was above guidance at 6.7%, which we approved. This year is at 1.2% aggregate as mentioned. We followed up with them and they are requesting a 0% charge master increase to effectuate this. And on the right, you can see how kind of a breakdown of how the aggregated rate increase is applied by location. So you can see just under 82%, if I can interpret that table for you, aggregated rate increase of 1.2%. Inpatient reflects 81.6% of their net patient revenue. And the aggregated rate increase isolated just inpatient is 0.7%. Outpatient makes up a much smaller percent of their overall net revenue at 16%, but the aggregated rate increase is a little higher at 1.7%, and professional 2.2% of their NPR, but the aggregated rate increase of 1.9%. Again, all those under the benchmarks established. The retreats made the following assumptions in regard to their public payer rates. So for Medicaid, they're modeling 0% increases for both inpatient per diem rate as well as outpatient, which has remained the same for many years. For the Children's Center, reimbursements are cost-based, but subject to some exclusions. For Medicare, they are modeling 2.8% rate increase in aggregate, which is based off the CMS rate of 2.6 to 2.8%. And they modeled a rate increase of 0.1% for Medicare Advantage, which my understanding is based on their current run rates. Utilization. So walking through this chart really quick, the top row is the weight of service line based on the FY25 NPR. So inpatient, like I said, is the bulk, 85.2%, 5.3% outpatient, 2.1% professional, and 7.3% children and adolescent residential budgeted. So that adds up to 100% of their service lines. The next row demonstrates utilization expectations, followed by payer mix movement. And the last row is the combination of these two, which reflects the non-rate growth associated at each of those locations. So for inpatient, we're seeing a small uptick in utilization, mostly due to expanding daily census, followed by a drop in payer mix in commercial and Medicare. In outpatient, there's intensive growth, mostly due to expansion in the intensive outpatient program, including the launch of the adolescent beginning in March, as well as increased utilization in the specialty medication clinic. Professional is a relatively small contributor to their net patient revenue, and non-rate growth is remaining relatively flat. There is a decrease in payer mix in commercial and Medicare with a slight offset to Medicaid, with an offset in utilization in all payers. So there's quite a bit of expected growth in the residential unit, and while this was baked into the FY25 approved budget, these are revised estimates, and they still include a ramp-up period. Excuse me. Looking to their labor assumptions, the retreat is remaining fairly stable in the clinical to non-clinical ratio. They are adding a VP of quality and patient safety position and continuing to work on replacing contract labor with W-2 staff. So some initiatives spoken to in their narrative include strengthening the nursing pipeline and launching a nursing residency program, strengthening and expanding the MHT training, mental health technician training, a preceptor program, as well as tuition assistance and continuing education alongside internships. So, there's their labor assumptions. I want to highlight some of the work they've done at reducing travelers at the retreat. This top table, should not have clicked. This top table here does a very, very rough comparison of the Brattleboro retreat's reduction in contract labor to the available data we have from other hospitals in Vermont over from mid 2025 to their budgeted submissions. And while you're seeing consistent reduction across the system and reliance on contract labor, the retreat's really done a fantastic job here, and we're seeing evidence of them reducing this even quicker than the other hospitals. So that being said, from their narrative, contract labor does account for about 9.5% of their FY26 labor budget. And the largest source for contract labor for the retreat includes nursing and mental health tech. There's a spike in mid to 2025, which you can see on the table above. It increasing from 47.5 to 55 during the EMR go live. However, as of November, the amount of contract labor was down to 31, and so you can, even lower than here. So other areas that have been seeing significant reductions include social work, which have dropped from 13 in 2024 to currently 2 contract employees. Looking at a comparison of salaries for the hospital's executive and clinical leadership with those of the hospital's lowest paid employees who deliver the care directly to patients, the retreat supplied us with the table shown and gave a ratio of average non-clinical executive labor salary to their base mental health technician, their lowest paid direct care position of about 5.3 to 1. This compares very, very favorably with other hospitals in our system. This is one of the better ratios we've seen. Looking at, there's relatively little data historically here at the Care Board for the retreat, since we only started establishing their budgets in 2024. We don't have the decades-long data that we can pull from like we do for the other hospitals. But in 2024, you can see the retreat over budgeted both revenues and expenses. But for 2025, they're projected to be within 1% of what was budgeted. So a much closer budget. Operating revenue, which includes NPR and other operating revenue, are expected to exceed budget by 0.4% for 2025, and expenses to exceed budget by 0.7%, which is very, very close to their budget amounts. Here are some previous assumptions around their payer revenue. Again, we have limited data by payer for 2024 because of how we collected the payer breakdown. So it's really more we can compare their budget to projected for 25. Looking at that view, 2025 is projected to fall short in all areas. So 7.4% short in commercial, 4.9 in Medicaid, and 21 in Medicare. Largest dips in commercial Medicare are mostly due to the additional purchase beds by Medicaid, which began in 2025, as well as reduced demand, which the retreat spoke to in the response to our questions on the 8th. A large contributor to the Medicaid budget actuals variance here is just the delay in the start of the adolescent residential unit. So these variances are mostly due to that rather than anything more material, I'd say. So looking at the 2025 to 26 budget, we can see a slight uptick in commercial, mostly due to expanding outpatient programs, offset by some decrease in inpatient demand. The retreat spoke to increased efficiencies due to the new EMR system as a driver of that, as well as the adolescent IOP program starting in March. The retreat in follow-up stated that the Medicaid increase and Medicare decrease are reflective of utilization trends seen in 2025. Luckily, we do have budgeted income for 24 and 25. So in 2024, the retreat overestimated NPR with a minor offset in other operating revenue. This was largely due to lower utilization than anticipated, offset by bad debt and free care coming in more favorably than expected. Operating expenses also came in under budget. Contract labor was 10 million under budget, but the offset to this was higher than anticipated salaries. The net outcome, however, was savings. For 2025, NPR is coming in much lower than expected, which is, again, like I mentioned, from the delay of the adolescent residential facility. If you look at the projections, it's much closer in line. Again, it's kind of a nuance with how we budget from approved budget to submitted budget, or look at percentages in that respect. The reduced NPR from the adolescent residential facility is offset by slightly higher outpatient, particularly in commercial for 25. So looking at the chart on the right, you can see that the large offset to 2025 NPR was due to other operating revenue. And here this was due to the employee retention credit they received, leading to a positive operating margin of $346,000. We're going to look at some high-level financial ratios here. So this slide shows their days cash on hand and current ratio. Days cash on hand was budgeted to drop down to 50 in 2025, but the current projections are at nearly 70. They're also budgeting 65 for FY26 and have noted in there they have a goal to improve this to 80 days cash on hand in FY26. Days cash on hand, I'll note, is less than 80 is considered highly vulnerable according to S&P's global ratings. So this would be a great improvement for the retreat. The current ratio has improved since 2024 and is currently at 3.7. The budgeting the same as FY26. Of note here is that the retreat did not report any unrestricted funded depreciation, so only current assets and liabilities are included here. Looking at their days in patient's accounts receivable, it appears to have jumped significantly between FY24 and the 26 budget. The primary reason for this, however, is due to the change in their EMR. The retreat noted the previous EMR had significant limitations in revenue cycle capabilities and could not record unbilled charges. So kind of it had the effect of deflating the appearance of their days in patient AR in prior years. So that the 50 days, 52 days, 56 days you're seeing now, that's it's below average in performance, but more realistic and more importantly, there's not a jump from 16 days to 52 days. It's more that the 16 days is not as accurate as we'd like to see. So age of plants remain consistent at around 22 to 24. This is highly vulnerable, and I think as they noted, they're one of the oldest plants in the state. Moving to productivity and access, as mentioned previously, the retreat had a new EMR go live in July of this year. They're currently working to leverage clinician productivity tools in their new EMR, so the data is not available for this year. Of note, they're making a $250,000 investment in an agreement with Rescue Inc. to provide expedited transport for patients waiting to receive inpatient treatment. They're doing this at any ED in Vermont to the retreat. They're saying this investment's made a large impact on ED wait times. Also of note is the retreat's improvement to access in their outpatient clinic. As you can see here, at the beginning of the year, they had over 277 people on the wait list. with an average wait list of a year and a half to 22 months. As of November, the wait list has dropped to 20 people, and they anticipate no wait list by January. So we're just gonna do a couple slides on quality reports at the retreat. So on this slide, these quality measures are areas where the retreat falls below both the state and national average. An important note here, however, we found is that the retreat's previous EMR had some fundamental flaws that resulted in challenges with data documentation, collection, and analysis. So the retreat pointed out that there was no specific data area to document tobacco use treatment provided or offered at discharge, which is likely why those two metrics perform so poorly compared to the state and national trends. If you look at the last two here, patient safety metrics, the retreat notes that they have reinvigorated attention to the 6 core strategies to reduce seclusion and restraint with a goal to eliminate the need for such interventions in their hospital care. And as I mentioned at the outset, they've also hired a vice president of quality and patient safety in August and continue to evolve and review their procedures. For more information on this, I'd recommend you refer to the retreat's response to the hearing follow-up questions that are available on our website. And on this slide, we're going to look at some measures that are performing well above the state average. So of note, 100% of patients with alcohol abuse received a brief intervention during their stay. And the following 3 measures also speak to higher than average rates of patient awareness and follow-up care. So all that leads to staff recommending that the board approve their budget as submitted, with NPR growth as requested at 3.5%, commercial reimbursement rate in aggregate of 1.2%, and expense growth as requested at 2.8% above their 2025 approved budgets. We have some proposed motion language available here, and Chair Foster, I will pass it back to you.
Thank you very much, Matt. I'm going to go ahead and make the motion, and then we can have board discussion. I move to approve Brattleboro Retreat's budget as submitted, with total NPR approved at not more than 3.5% over fiscal year 25 approved budget, with a total NPR of not more than $101,644,022. Commercial NPR approved at not more than $14,731,804. Commercial reimbursement rate approved at not more than 1.2% over current approved levels, with payer-specific rates approved at not more than the figures presented in Brattleboro Retreat's proposed budget, and subject to all other standard conditions as presented by staff today.
I'll second.
Great, thank you. I'll brief comment. It's really nice to see Brattleboro Retreat seemingly pretty steady and solid and making a lot of improvements in targeted areas. So I really appreciated that. I think the retreat's in a good place, and I really appreciate that they came in at guidance. It makes our job a little bit easier, and thank you for the work. And I'll open up to any other board members for comment or discussion.
I can just hop in there and just say thank you, to Brattleboro Retreat. I've noticed a lot of progress, in the last year or two, and particularly I want to note the reduction in wait times and the reduction in travelers. I know that's hard work, and as a Vermonter, I really appreciate that hard work. I want to thank the hospital finance team for a great analysis here, and also the Brattleboro Retreat for clear responses to our follow-up questions. So I would support this motion language.
I'd also thank the staff, and I do appreciate Brattleboro's responsiveness, timeliness with this, and just as Member Holmes said, the progress with workforce stabilization and wait times is impressive. I don't have any hesitation to go with the staff recommendation.
And I'll just piggyback on a brief comment as well. The one thing I just really want to highlight, in addition, that as an emergency physician, I'm highly appreciative of, is the work that Brattleboro has done with transporting patients expeditiously to receive care at the most appropriate setting. It makes a huge difference in patients' lives and a huge difference in the functioning of an emergency department in Vermont. So I appreciate that very much, and I just wanted to highlight that. But also, I agree with the others' comments and really appreciate the hospital finance team work and presentation on this. So thanks, Matt.
Any comment from the healthcare advocate?
Just a brief one. Thank you, Matt and team, and we support the motion before the board. Happy Friday, all.
Thank you very much, Sam. And I'll open up to public comment via raise the hand. Okay, seeing none, all in favor of the motion, please say aye.
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 Aye, and the motion carries 4-0, and member Teach Out is not here today. Thank you very much, Mr. Cummings and your team for the budget submission and your hard work. Keep it up.
Thank you very much. We appreciate the opportunity. We'll keep
All
going.
right. Happy holidays and have a great weekend.
Thank you.
Okay. Mr. Sutter, I see that there's more slides for today.
Yeah, so we also have, these are on the website. We also have some appendix slides. These are just kind of provide some more detail about the statutes we reference. I encourage people to reference if they like some more detail here, but we didn't think they were necessary to review today in the full hearing.
Great. All right, well, thank you very much to you and your team for your work. And is there any other new or old business for the board? Okay, then I move that we adjourn.
Second.
All in favor, say aye.
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 Aye, we're adjourned. And thank you, Jackie, for your help today. Everyone have a nice day.